Good evening, everyone. Welcome to Consensus or Controversy. My name is Sara Tolaney. I'm a breast oncologist at Dana-Farber, and I'll be moderating today's session. I will be stepping in for Neil Love, and those are some very big shoes to fill, but we are going to have a fun evening this evening, and we're going to keep it exciting. So, please do stay engaged and keep questions coming in. I am joined by an incredible group of faculty this evening. So Dr. Sara A Hurvitz is coming to us from the Fred Hutch. Dr. Erica Mayer is actually my colleague at Dana-Farber. Dr. Joyce O'Shaughnessy is at Texas Oncology, Sarah Cannon Research Institute. And Dr. Nick Turner is from the Royal Marsden. So really an incredible group of faculty. Prior to this evening's session, we did survey our esteemed faculty. We also surveyed Dr. Kaklamani, so her answers will be included in the survey responses. So really it's great to have everyone's input on all the areas of controversy. Shown here are the disclosures for all of our faculty members, so you can see these here. And so these are disclosures for research to practice. This activity is supported by educational grants from AstraZeneca, Celcuity, Genentech, Roche, Lilly, and Stemline. And research to practice, CME planning committee members, staff, and reviewers have no relevant financial relationships to disclose. This educational activity does contain discussion of non-FDA-approved uses of agents and regimens, so please do refer to official prescribing information for each product for approved indications. So we are going to dig into our program. We have a lot to cover in a short time frame. So tonight's program is really focused on oral SERDs and PI3K pathway inhibitors. Here's our agenda for this evening. We'll first start off with Dr. Turner giving us an overview of the PI3K pathway and oral SERDs in the first-line setting. Then Dr. O'Shaughnessy is going to turn to oral SERD monotherapy in setting of progressive disease. Dr. Mayer will then take us through oral SERD-containing combination regimens, and Dr. Hurvitz will talk about clinical utility of agents targeting the PI3K pathway in the resistant setting. And then I'll conclude with the use of SERDs in the adjuvant setting. So we're going to dig in. We'll have Nick start us off. So we'll turn to our oral SERDs. Thanks, Nick.
Well, thank you very much for that introduction. Well, good evening, everybody. So we're going to talk about the first-line setting. So we're going to talk about, first of all, patients who relapse on their adjuvant endocrine therapy before moving into the AI-sensitive alternative population. We're going to touch on current trials, and I was also just tasked to put a slide on biomarker testing in and after the first-line setting. Of course, for patients who relapse on their endocrine therapy, standard of care is fulvestrant and a CDK4/6 inhibitor, and I have here the 3 randomized trials that, of course, have cemented this as our standard of care. However, preclinically, it's very clear that for those cancers that have PIK3CA mutations, there's really substantial benefit from adding in a PI3 kinase inhibitor to this doublet therapy. And we're really sort of targeting the fundamental 3 aspects of the biology of these cancers. And this also translates to very impressive preclinical efficacy in patient-derived models, where combining PI3 kinase and a CDK4/6 inhibitor together really gets substantial efficacy, blocking the outgrowth of resistant clones to one of those drugs. But the challenge has been translating this and identifying a triplet that's tolerable in the clinic. And this ultimately led to the INAVO 120 study with the alpha selective PI3 kinase inhibitor inavolisib that selectively degrades the mutant PIK3CA mutation. And what was unique about inavolisib is you could combine it in the triplet with all 3 doses given at their maximum tolerated dose. And of course, INAVO randomized patients in the first line with PIK3CA mutant breast cancer relapsing on their endocrine therapy between palbo fulvestrant and the addition of inavolisib. And we saw a substantial improvement in progression-free survival over doubling with a hazard ratio of 0.43. We also saw a statistically significant improvement in overall survival by the addition of narvolizumab. And one thing I think it's sort of important to highlight in this patient population, if we look at the 6-month time point, in the control arm, 10% of patients had unfortunately died just 6 months into their therapy. One of the aspects that really advocates for coming in with triplet, the most effective therapy, at the start of therapy. So looking at the other endpoints, there was a substantial improvement in objective response rate up to 62%. And if you like, confirming the preclinical data, the duration of response was also substantially longer by narvolizumab, perhaps suggesting you are blocking routes to the cancer becoming resistant. But of course, adding in a PI3 kinase inhibitor brings side effects to the therapy that is familiar to all of us. So what are the ongoing trials in the first-line setting in the endocrine resistant? So there are 2 trials that are looking at alternative triplets with gedatolisib, the IV PI3 kinase mTOR inhibitor that Dr. Hurvitz, I'm sure, will be telling us about later, as well as capivasertib, the AKT inhibitor, similar kind of design, but without biomarker selection in the first-line setting. The other study in the first-line setting is Pioneer. So this is looking at alternatively switching from fulvestrant to the oral SERD giredestrant and asking if that can improve efficacy. And this study is specifically enriched for ESR1 mutations. So about 15% of patients who relapse on their adjuvant AI are going to have an ESR1 mutation. And this study is also enriched further beyond that to look overall, but also specifically look in the subset of patients that have ESR1 mutations. But let's switch to the alternative group of first-line patients, of course, much more common, which are those patients who are potentially sensitive to AI, where, of course, again, AI and CDK4/6 has become the standard of care. What have we looked at in these? So we've got 2 studies that have looked at how we can integrate SERDs into the first line, one reporting in this year's ASCO, but the one we reported at last year's ASCO was SERENA-6. And this was the study that looked at monitoring for the evolution, the development of ESR1 mutations in circulating tumor DNA. 3,200 patients went into the ESR1 mutation surveillance. And from this cohort, 540 patients where ESR1 mutation were detected, and these were used to randomize 315 patients prior to progression. So picking up those ESR1 estrogen receptor mutations evolving in the cancer before progression. And these patients were randomized, 315 of them, 1-to-1, double-blind, to just continuing the same therapy of AI and their CDK4/6 inhibitor, or switching to the oral SERD camizestrant that we know is highly active against these ESR1 mutations, and continuing the same CDK4/6 inhibitor with the primary endpoint of PFS. And we saw in these studies for these patients who are getting molecular progression but without actually clinical progression, you could substantially improve PFS by switching to camizestrant, over doubling PFS with a hazard ratio of 0.44. And also, by switching to camizestrant, you could improve quality of life. So it was a relatively steep decline in quality of life of patients who stayed on their AI, but improvement by switching to camizestrant. Now, what are other first-line studies that are looking at SERDs? So SERENA-4 is not going to report out yet. So this was a study of 1,300 patients looking at randomizing between anastrozole and camizestrant, same oral SERD as in SERENA-4. And then we have Persevera that is reporting at this year's ASCO that randomized between letrozole and giredestrant, another oral SERD. Again, we'll hear more about both of these drugs later on today. And so we know from a press release that this study did not demonstrate a statistically significant improvement in PFS, and we're going to show the results on Tuesday. So if we look to moving oral SERDs into the first-line setting, is the best option with ESR1 surveillance? Let's look at the update of SERENA-6 as well on Tuesday, and then it would be great to have a discussion about that. Now, there are other trials in the first-line setting ongoing that are asking interesting questions. So OPERA is with a very similar study to the two studies we've just looked at with palazestrant. So this is a complete estrogen receptor antagonist. We've got a study specifically for BRCA1 or BRCA2 mutation carriers. There's a lot of data that suggests these people do less well on CDK4/6 inhibitors. And so this study is looking at, well, should we be bringing PARP inhibitors for them into the first-line setting instead of a CDK4/6 inhibitor? So this study randomizing between CDK4/6 and a PARP1 selective inhibitor, saruparib. We have FORLIGHT-3, which is looking at switching out standard CDK4/6 to a selective CDK4 inhibitor, atirmociclib. And then we've got the first of the triplet studies that are moving into this AI-sensitive group, INAVO123, in PIK3CA mutant cancers, looking at adding in inavolisib as a triplet to AI and CDK4/6. And these are going to be really interesting studies when they report out on how we can improve the first-line setting. And then just in my last slide, I was asked to talk a little bit about biomarker testing. And so where I think we're standing, and I think we might be talking about this in the answer to some of the questions. So if we look at patients who are relapsing, of course, standard of care is to try and do a biopsy and to do tissue somatic testing on that biopsy, as well as, of course, testing HER2. So we're thinking about which ADC we might be wanting to give that patient at the appropriate time in the future, as well as, of course, germline testing. And then after progression, potentially repeating the liquid biopsy to identify those patients who've got ESR1 mutations and retest for PIK3CA, AKT pathway mutations that might have changed in the cancer through first-line setting. In the AI-sensitive population, it's quite similar, but of course we might be implementing ctDNA ESR1 mutation monitoring if the study were to get regulatory approval. And that's my last slide.
Well, thank you very much, Nick. That was a tour de force. So we're going to dig into some of the survey questions that I think really try to hone in on some of the challenges that we're facing in this first-line space. So one of the first questions that we asked the faculty was, at what point do you typically first assess alterations in your patients with hormone receptor positive disease? Is it really just at time of diagnosis, or are people waiting? But you can see most people are getting mutational status at the time of diagnosis, but I think many are additionally getting it at time of progression. Nick, it looks like you also do it at both time points. How are you doing it up front? Particularly, if someone, for example, may have early relapse, are you trying to get a ctDNA at baseline so you know quickly if someone has a PI3K mutation, or how do you figure that out?
Yeah, I think that is heading. I think if you can get tissue testing quickly, then that is probably the gold standard is to do it on the tissue biopsy when patients are relapsing. But actually, if you're going to think about getting someone an inavolisib, getting it done as a liquid biopsy to get rapid PIK3CA testing, I think makes a lot of sense.
Yeah, I will say at our institution, we're often sending both tissue and blood at baseline, particularly in the early relapsers, because of that quick return of results so that we know their mutation status up front. So we'll put this into context. So which first-line treatment would you recommend for a 65-year-old woman who has hormone receptor positive, HER2-low breast cancer, who develops metastatic disease after 2 years of AI therapy? This patient did get genomic testing and is found to have a PI3K mutation. but is ESR wild type and BRCA wild type. So we did ask our faculty members what they would do here, and you can see pretty much across the board, there wasn't much controversy here. This is someone who relapsed quickly on adjuvant endocrine therapy, had not seen an CDK in the adjuvant setting, so really did fit in an AVO 120 type population. So everyone's pretty consistent here. So now what if you have someone who has ER positive, HER2 low disease with minimally symptomatic bone mets, who gets 2 years of an adjuvant AI and CDK4/6 inhibitor, and now is PI3K mutant, ESR1 wild type? What are you going to do here? And here we do have a little bit of difference in opinion. This patient does fall outside of a typical ANAVO 120 patient since they did get a CDK4/6 inhibitor. Sarah, maybe I'll ask you. You did pick giving fulvestrant capi and not using the ANAVO regimen. What was your rationale there?
Well, because I knew Nick would say it, so
it must be right.
and I'm in good company. I really struggled with this one. I think, the questions that come to us are always, they start easy and get a little bit more murky as you go. And so I really don't think that ANAVO is the wrong choice. I guess I was just thinking this patient wouldn't have perfectly matched the ANAVO 120 patient population. I don't have a lot of faith in the added benefit of palbo after abema, and that's where I went with that. But maybe, Nick, you have a more elegant explanation.
No, my thinking was just the same as you, Sarah. This is a big uncertainty. What do we do with these patients who relapse early after their adjuvant CDK4/6 inhibitor? We really need data in this setting, and that's why I also didn't think palbo would likely be contributing much in this setting.
How about you, Joyce? You seem to feel okay with ANAVO palbo fulvestrant.
Yeah, we know there's a yin and the yang between the PI3 kinase mutations and the CDK4/6. So it's kind of like one of blocking all the exits type of thing. We know it's a safe regimen as long as her hemoglobin A1C is good, but it was more just giving her the best possible shot on goal because she's got very bad disease.
Yeah. Oh, it's a tough situation, and you can see not a wrong or a right. Here we do have more consistency. So would you offer ANAVO palbo fulvestrant to a patient with de novo PI3K mutant hormone receptor positive disease under any circumstance? So again, this is an endocrine sensitive patient population. This would not be someone who met ANAVO 120 criteria. And here the faculty were very consistent that they would not give a triplet in this situation, even if they had a PI3K mutation. So now we get into a little bit more controversy. So one is, do you believe the results from SERENA-6, and do they justify the routine use of serial ctDNA monitoring for early detection of ESR1 mutations in patients with hormone receptor positive disease getting first-line therapy? And if you do, would you get ctDNA analysis, and how often? So here you can see there's a little bit of differing opinions. Some are saying they would start doing the ctDNA monitoring, but others not. So, Sarah, I'm going to put you on the spot again. Here you're a bit of an outlier. You want to tell us why you're not on board?
Well, first I want to clarify, I do believe the results of SERENA-6, but I'm not sure they yet justify the routine use. We had a discussion there. We have 15 breast oncologists in our group now, and we had a very passionate discussion about these results and about whether or not we should be doing ctDNA in this setting, but also in the early stage setting. And Heather Parsons, who recently joined our group, happens to be pretty expert in the ctDNA realm. And we all came to consensus that we felt it was just a wee bit too early. We'd like a little more data. Having seen so many patients come through, seeing the wobbling in ctDNA, not really seeing survival benefit long-term. There were issues with the SERENA-6. All respect intended, Nick, and you can jump on me in a moment to take over. But I think that, it just, there's a lot of anxiety, and without the long-term survival benefit and not knowing that we can't help those patients when they clinically progress by switching. There wasn't a crossover in SERENA-6, among other things. We're not quite ready, but it may change after this meeting. We'll see.
Oh. Well, Erica, obviously you were very involved in SERENA-6. It sounds like you're comfortable. Maybe you could tell us a little bit about that, and maybe also answer when would you start doing ctDNA screening if you were to start doing, and how do you come to that decision?
Yeah, so first of all, I think it's interesting that of the four of us who said yes, we basically all said the same thing. And Nick once said something to me that stuck in my head, which is in SERENA-6, the screening for ctDNA was every 2 to 3 months, meant to correspond to the time of restaging. But every 3 months is basically 4 times a year. And for some reason, that feels very reasonable and manageable. So thank you for that language. I am a believer in SERENA-6. I do think that not only is the primary endpoint of prolongation and PFS compelling, but the quality of life data that Nick showed is really very meaningful. The patients who made the early switch at emergence of the ESR1 mutation had over 1.5 years in prolongation in deterioration in quality of life. And when you break down the quality of life data, the symptoms that were delayed were symptoms of pain, fatigue, shortness of breath. These are the symptoms of subclinical cancer progression. So I do think that I do think it's making a very meaningful difference in patients' lives, not only in the prolongation of PFS, but in helping that time be better and feeling better. Just a few weeks ago at ESMO Breast, there was an update looking at the testing itself and showing that in the first few years 1 to 4, were the times when there was the greatest likelihood of ESR1 positivity at time of first test. So that might be somewhat identifying a bit of a sweet spot when, if we're going to test, we are more likely to find it. And also if patients had about 4 to 5 tests in a row, that picked up about 20% of all the mutations. So I do think that we're not looking at just open-ended testing everybody indefinitely, but I do think that it would be helpful to refine a little bit where that sweet spot exists. We do know that eligibility for screening was for patients who had been on therapy at least 6 months, and I think we all kind of feel like you have to be on about a year before we'd initiate testing. But I wouldn't be doing this indefinitely. I think at some point you stop and you say, it's not there, we're going to just carry on. But I do think it's something I would like to adopt if possible.
Well, we just had a pretty controversial FDA ODAC discussion on this. And so, maybe Joyce, I'd love to get your thoughts on that, because the vote was against recommending approval here. And I'd love to get your thoughts on maybe what you thought of that discussion and which way you would lead.
So I listened into the ODAC discussions, and it was a 6-3 vote, and the 6, there were a couple of statisticians and a patient vote against, and then the others were basically docs who wanted to see the question answered of, do we change therapy at molecular progression versus changing therapy at clinical progression? Give me a randomized trial where the oral SERD would come in after the progression by clinical progression. This trial was started in 2020. There were no oral SERDs at that time to do that. Plus the fact it's a registration trial. That question that the ODAC members really wanted from a clinical perspective is a very valid question, but it just shouldn't be part of a registration trial. You can't do all things in one trial. It was really this whole thing about, should we change now at molecular progression? And I'll tell you something, I'm learning how terrible this ESR1 mutation is. I've been reading about the biology of it. I don't think a lot of us appreciate that this is a bad actor. It's liver tropic. It makes the cancer cells liver tropic. For example, it makes the size of the circulating tumor cell clumps bigger because it increases adhesion and metastasis. This is a bad actor. And we want these drugs to work as fast, as well and as long as possible. We don't want polyclonal ESR1. We know the drugs don't work as well with lots of different ESR1 mutations. We want to get in there early for these patients. And I think the quality of life data are real. And this is a big, big improvement in stopping deterioration in quality of life. This is a bad actor. So I think I'm hopeful that, the FDA is kind of reevaluating things. There's more data coming that we'll hear about on Tuesday, et cetera. So I'm hopeful. And I think a lot of the oncology community has said, wait a minute, what are you doing here? You know what I mean? So I think I'm hopeful that maybe things will change.
Well, one of the comments from our audience was this comment about that you brought up that the control arm didn't get sequential SERD.
Exactly.
And so evaluation of PFS2 becomes a bit limited without having that crossover.
Right. And I'm not a PFS2 fan. I think PFS1, that's the primary endpoint of the trial, quality of life. Very, very important. And there's this nice tail on the curve that Nick just showed just now, 30% still progression-free at 2 years, which is very nice. So, yeah, PFS2, in the new molecular detection age, PFS2 kind of needs to be rethought, I think.
That's a fair point. So here, do you believe the results from SERENA-6 justify an early change in therapy? Again, we see a little bit of a controversy here, as we kind of discussed. Do you anticipate that Cami will receive regulatory approval? I think we heard that it's uncertain, given what we've heard from the ODAC, but it seems like they are willing to receive more data, and that some of that data is going to be presented here on Tuesday. So we'll eagerly await that and certainly learn more. So, maybe we'll shift gears and we'll turn to Joyce, who's going to talk about oral SERDs as monotherapy in the ER-positive setting.
Great, thank you very much. Now, I'll go fairly quickly because I think a lot of these data are very well known to people. It's really great that we have these agents now that can go after this mutant ESR1. Like I said, these are biologically very aggressive. They increase metastagenicity. And the survival with these ESR1 mutations is only in post-CDK4/6 without an oral SERD is only like in the 19 to 23 month range. So it is really good that we have these agents now. I think it'll be unacceptable to give somebody a treatment who's got an ESR1, an endocrine therapy treatment, if we don't have an oral SERD to give the patients. And so I won't belabor this. There are many of them. They tend to they're so important to drive the cancers that they tend to be polyclonal over time. And it's clear that if you got a lot of ESR mutations, the oral SERDs don't work as well. An argument, I think. And also, we don't want a lot of clonal heterogeneity. We don't want a whole lot of other mutations in there. We want to give these agents a chance to work as well as they possibly can, as early as possible in the natural history. And everyone's aware of the Emerald trial with elacestrant, 100%. It had a prior CDK4/6, and it was mostly fulvestrant they got versus elacestrant. About half had an ESR1 mutation. And in the ESR1 mutant population, the median progression-free survival was 3.7 months, and that's a hazard of 0.5. And you can see this tail on the curve again, 30% of patients going out fairly well. Again, this is very, very good to see. There is this fall off here, that we do need to understand who are these patients that do not benefit, and we need to see co-mutation data, et cetera, to better understand those patients. But one thing we did learn is that you can have fewer patients progressing at the first scan if they were on their CDK for at least 12 months. Now you're getting up into median PFSs of 8.6 months or so. So that was very helpful to us in the clinic too. It's better if patients are not really endocrine therapy resistant. This is a better strategy for those patients. Now, if they're ESR1 and PIK3CA co-mutant, it was about a 5.5 month median PFS, visceral disease 7. So this is a very, very important driver, even with the PIK3CA, even with the P53, even with HER2 low. I think this is really the dominant, this is a transcription factor. You can have mutations upstream of transcription factors, and they can cause resistance down the road, but transcription factors are really what drive this cancer. And so I think this is a really defining mutation for these patients when these cancers develop ESR1 mutations. So the real-world data now has gotten coming up in the world. I'm going to show you 2 studies published in 2026 in clinical cancer research. It's hard to get things published in clinical cancer research. And so I looked at these pretty carefully. This is real-world evidence from elacestrant single agent. And this first one is the Lloyd paper, the Lloyd and Seth Wander paper, where they worked with Guardant Inform, and they looked at the Guardant ctDNA database that's hooked into a insurance database, an insurance aggregator. All the insurance companies, or many of the insurance companies in the country, have all of the data in terms of when the elacestrant was ordered, when the elacestrant was discontinued, when they went on to their next therapy. That's very accurate data. It's felt to be a quite good surrogate for progression-free survival, especially time to next treatment. Time to treatment discontinuation, there's an argument in the literature, how good is that? But time to next treatment kind of comes up as probably the best surrogate when looking at these insurance aggregator databases for when, how long patients benefited from the elacestrant. So they looked at the Guardant-informed database on the ESR1 mutant patients who received elacestrant. And basically what we're seeing here is that it's a very nice paper full of information, and that the median PFS in those who had only had one prior line of therapy was about 8 months, and if they had had 2 or 3 prior lines of therapy, it was down around 6 months or so. And then PIK3CA mutation altered versus unaltered, we can see it was about 6 versus 4.2 months. I was impressed that these data are kind of going along with what we saw in Emerald. They're looking very similar to me, so this was actually quite good to see. And then this looks at prior fulvestrant versus not. Patients did better if they had not had prior fulvestrant here, 7 versus 6 months. So earlier lines of therapy is better, no prior fulvestrant, and fewer lines of prior therapy. The other one was published by Hope Rugo and colleagues in clinical cancer research, again, very recently. And they used the Komodo research database. This is another one of the insurance claims aggregators. So when did the claim go in for elacestrant? When did the claims stop, when it was discontinued? And when was the time to next treatment? And they looked at those patients who were receiving elacestrant. They also did have access to the Foundation Medicine database as well for ctDNA evaluation, patients who had ctDNA positivity. And basically, in this group of patients who were getting elacestrant, 93% of them had had a prior CDK4/6 inhibitor, so we're kind of all doing that. And interestingly, about 94% had been on their CDK4/6 for at least 12 months. So we're actually following what was found in the Emerald study. It was interesting. PIK3CA mutations were 43%, P10 about 6%, 6% about with AKT mutations as well, and about 20% were polyclonal there. So very, very interesting. So the time to next treatment benefit we can see was really quite good. It was about 8% here, if I can read this, and 8% over here with three or more lines of therapy. It's a little bit lower here. But it's tracking very nicely with the Emerald database here. And here we can see a list of the median time to next treatment, 1 or 2 prior lines, 8. You can just look down here and co-mutations here, 6 months. So again, very, very similar. Both the Wander paper and the Rugo paper are agreeing with each other. So this is very good to see. And I think these studies are going to become increasingly important to us in clinical practice. Recently, we had imlunestrant approved, another oral SERD based on the Emerald 3 trial. And these patients, about 60% of them had a prior CDK4/6. They were all required to have had recurred on adjuvant endocrine therapy or progressed on first-line endocrine therapy. And it was imlunestrant versus standard of care endocrine, which was mostly fulvestrant, versus the combination with abemaciclib. And about 40% had an ESR1 mutation, about 40% had a PIK3CA mutation, about 60% had the prior CDK4/6 inhibitor. Now, so this is a less heavily pretreated population than the Emerald trial. We see the median PFS of 5.5 months. We see the hazard here as well of 0.62 and is highly significant. And interestingly, both elacestrant and imlunestrant have some CNS penetration, but I did not realize that patients with ESR1 mutations had a higher proclivity to develop CNS metastasis, and that was actually quite dampened by the use of the imlunestrant. So this is really very good to see in the patients with ESR1 mutations. Just focusing on imlunestrant single agent here in patients with a co-mutation, this combination didn't have the 5.5 that we saw with elacestrant. But again, these are small data sets, and we certainly need more numbers to fully understand that. And then I was intrigued by the survival. Again, it's not statistically significant, although the p-value looks significant, but it didn't meet the pre-specified threshold for the p-value. But there's about an 11-month improvement in overall survival here in favor of the imlunestrant versus single-agent imlunestrant versus the endocrine therapy. Just to finish real quick, because this drug just became available to us in practice in the last couple of weeks. This is a super cool agent where it's engineered, where one end of it binds to the estrogen receptor. The other end of it binds to the E3 ubiquitin ligase, and it brings these two moieties in very close proximity. So the E3 ligase can ubiquinate and then lead to the degradation of the estrogen receptor. Very, very elegant. These patients 100% had a prior CDK, Vepdeg versus fulvestrant. It's daily oral. PFS in the mutant population, and again, 100% had a prior CDK4/6, and we can see an improvement here. Again, a stat-sig improvement. I should say, in all of these trials, Vepdeg, imlunestrant, and elacestrant, in the wild-type non-mutant population, these agents are very similar to standard endocrine therapy. There's like a trend, a numerical trend in favor of the oral SERD, but the real differential benefit is clearly in the context of the ESR1 mutation. The median PFS here of about 5 months or so, and this is in all patients here. You can see the slight trend. Very, very safe, very low-grade toxicity in a very small percentage of patients. Again, interestingly, if patients had been on their prior CDK at least 12 months, they were getting up at higher median PFSs here, pushing up around 6 months or so, compared to really not getting that 12 months on their CDK4/6. Intriguingly, with or without liver mets, both the patients tended to benefit more from the Vepdeg compared to the fulvestrant. And so toxicities, nausea, if the patients take this with food, the nausea is ameliorated. With imlunestrant, they will take that on an empty stomach. It's needed to be that way for absorption. Little diarrhea, not much. Visual changes, very mild. Photopsia, very low-grade bradycardia, small percentage of patients. And then Vepdeg is taken with food for optimal absorption. It needs to be taken with food, including a fatty meal, and there's a slight decrease in the peak levels of it with a PPI, but it's only about 16%, so FDA did not put that in the label. That's important, but not bad for the patients to maybe know about that and take their PPI or H2 antagonist at a different time than their Vepdeg. I just wanted to finish with, this is a summary of what I went over, but dose reductions and dose discontinuations were extremely uncommon. These are very, very well-tolerated agents. So really very nice agents to have to go after this very poor prognosis mutation.
Thank you very much, Joyce. It's super helpful to put in context. And now, again, we do have another drug approved with Vepdeg and oral Protac. So we'll kind of dig into this a little bit and see what our faculty's preference is for use. So we'll start off with this question. Which treatment would you recommend for a 65-year-old woman with ER-positive, HER2-low breast cancer who develops minimally symptomatic bone mets after receiving riboletrozole in the first-line setting? This patient has an ESR1 mutation, but no PI3K pathway alteration. So we have two different scenarios. One is that the patient was on for a prolonged period of time on their upfront AI ribo for 2 years, and then another scenario where they maybe have more endocrine-resistant disease and they're not on it as long. So when someone's on their AI CDK for more than 2 years, I think most people seem to feel very comfortable with a SERD monotherapy. But I guess the question is, now what are you going to pick? We've got a lot of choices. It's kind of easy for us to write them all. But when the patient's sitting before us, we got to give one of them. So Sarah, which one are you going to order?
It's really going to depend on insurance, on their baseline. I mean, there are a lot of these factors. I really don't feel that there's a strong difference among them. We don't have any head-to-head data. I'm most familiar with elacestrant because it's been around the longest, and I suspect in the community that's why people will go for that first. But I don't have a strong preference in this particular scenario on the left side.
So can I ask, is anyone going to use vepdegestrant? It's the last one to market. It's a little different. It's a Protac. Are people going to prescribe it? We've now had a little bit more, you mentioned, Sarah, you're used to using elacestrant, but are you, maybe Joyce, are you going to use Vepdeg?
I've already prescribed it. I've already prescribed it for a patient. Now, she wasn't her first. She was on a trial where she got imlunestrant. She's one of these patients, mid-70s, bone only, really is really saying I'm very toxicity averse. So I wanted to give her another agent. So I thought, I'll give her Vepdeg. We don't have data for sequencing these, but there's no doubt in my mind we're going to be sequencing these things. And so, but I think she's got an ESR1 as a driving mutation in her cancer, and so I wanted to give her another one, but she already had the imlunestrant. So I am going to use it. I think a lot of us are going to be using, I probably, for the endocrine therapy sensitive patient, I'll probably stick with elacestrant. I know it. I'm familiar with it. But I'm going to sequence these, and I think that if we see some non-cross resistance, that's going to inform our practice over time. But I think we just need some more experience in the clinic and some more data.
What do you think about the QTC signal with Vepdeg? Is it something you're worried about? What are you going to do about EKG monitoring?
Yeah, and I didn't mention that. I should have put that on the slide, Sarah. Thank you. A QTC, we have to get a baseline, then we have to get one after, I think it's 4 weeks on trial. And again, just watch out for what they're on and stuff. It's one of these things that they didn't have any arrhythmias whatsoever, and so I kind of put it in the ribociclib category. It's something we need to do. We need to be aware of it. Occasionally we'll find somebody, and then we may need to do a dose reduction. But I'm not concerned about it, but I'm glad you mentioned that. That is part of the program now. Mm-hmm.
And so in the other scenario, we think about someone who maybe didn't get so long on their upfront AI-CDK. Erica, what are you going to do in that situation? It sounds like you don't feel comfortable with SERD monotherapy here. We do have a few different choices for what to do. How would you pick?
Yeah, so on the one hand, we've seen repetitively that patients who are on their first-line AI-CDK for at least 12 months or more are the ones who really are benefiting from oral SERD monotherapy. On the flip side, if a patient progresses within that period of time, I am concerned about the pace of disease, about resistance mutations, and about the need to think about using something more than monotherapy. I'll speak in a moment more about combinations, but I think this is really the situation where we want to think about how we can target crosstalk resistance. And here's where I think a SERD combination makes more sense. So I had voted for imlunestrant and abemaciclib in this situation. This way I can offer the oral SERD, but I'm also offering it with another agent to hopefully overcome resistance.
So Sarah and Nick were the outliers not choosing imluabema here. Maybe, Nick, you can tell us what your rationale here is for fulvestrant everolimus.
Well, I agree very much for the rationale of not giving a single-agent oral SERD. I guess what I hope soon we'll be able to use is everolimus and giredestrant.
Yeah.
And then we can combine with an oral SERD. But I picked what's available currently, and in this patient population, I would use everolimus and fulvestrant mostly, I think, because at the moment imlunestrant and abemaciclib doesn't have a license.
Yeah. So if you had it here in the U.S., we have this little asterisk in the NCCN guidelines where you can give imlunestrant to abemaciclib. So actually, I think many of us have prescribed and it's been getting covered. If you had it available to you, how would you pick? Would you give imluabema, or would you stick with your fulvestrant?
Once giredestrant is available,
that'd be your preference.
I would give someone
You'd
like
want
this,
the mTOR
giredestrant
inhibition.
and everolimus.
Okay, Sarah, sounds like you might be swinging that way too.
Yeah, and I've specifically had imlunestrant abemaciclib denied by insurance companies, but I told you Washington seems to be an outlier, very different. But I also don't have a ton of faith of abema after ribociclib. So I'd be waiting for that. I'm really hopeful that giredestrant and everolimus will be approved.
So what would you recommend for now an 80-year-old with poor performance status who gets riboletrozole for 2 years and has an ESR1 mutation and a PI3K mutation? Here, everyone was pretty consistent. We ignored the PI3 kinase mutation, and we just stuck with oral SERD. I think this was purely an age and performance status issue that people were probably not comfortable using a PI3 kinase inhibitor in this particular patient. But here, if you have a patient who starts off with letrozole ribo and responds, but then 18 months later develops disease progression and has an ESR1 mutation and a PI3 kinase mutation, gets fulvestrant abema, melanoma, responds, and then progresses again. And again, repeat biomarkers consistently show now ESR1 mutation, and I guess this actually does not have a PI3K alteration. So what are you going to do now? They've had AI CDK, and they've had fulvestrant with another CDK. What are you going to do now in this setting with a known ESR1 mutation? It looks like most people want to try SERD monotherapy here. Some differences in preference. Joyce, maybe why'd you pick imlunestrant in this particular scenario?
It's because recently I've seen some non-cross resistant with imlunestrant post-elacestrant. This patient has not had an oral SERD, but she's a little further into her natural history. She's had a bunch of therapy so far, so I'm afraid she's getting more endocrine therapy resistance. And I've also heard some other cases of patients having good responses later line to imlunestrant, even in a heavily pretreated population. So sort of leaning that way a little bit. Again, I need more experience in the clinic.
Oh. Will you use oral SERD monotherapy or vepdeg first for your patient with hormone receptor positive disease and ESR1? And, I think we touched upon this, that I think most people are kind of sticking to the oral SERD given their comfort level at this point in time. How would you indirectly compare global efficacy of elacestrant and imlunestrant when employed as monotherapy? Most people feel like it's about the same. Joyce is our outlier and thinks
I don't know what I was thinking. I was doing that. It was on the big screen, I mean, so, this must have been right around the time that my patient who had benefited from elacestrant, mid-70-year-old lady, she had gotten like 6-8 months on elacestrant bone only, and her markers are rising, and she's again toxicity averse, and she's had a beautiful response in her markers from elacestrant. So I was kind of talking about that, and then one of our colleagues mentioned a patient with liver mets going to hospice with that kind of liver dysfunction who had a very, very good response to single agent imlunestrant. So I'm like, whoa. So anyway, I'm intrigued. I'm intrigued. So that's why I think I put that down.
Okay. I think here, again, as people have noted, it's just hard to know across these different things. But clearly, it seems like the preference is oral SERD monotherapy in patients who've had prolonged benefit to upfront CDK. So now we're going to turn into the combination strategy. So Eric will guide us through this.
Thank you. So those questions were great teasers to get us excited about the idea of combining oral SERDs with targeted partners, particularly in situations of cross-resistance. So we know there are multiple signaling pathways that are active in the setting of endocrine resistance, and this includes through the ER pathway, CDK4/6, and the PI3 kinase pathway. So continued and comprehensive suppression of these signaling pathways beyond progression may help improve patient outcomes, and this is the rationale for using co-targeting with an oral SERD and a targeted partner to provide synergistic activity and help overcome this resistance. You can see an example of this based on Avera on the lower left, where you have giredestrant targeting the estrogen receptor, everolimus targeting mTOR to help overcome cross-resistance. And in preclinical models, this is for EMBER-3, looking at how the combination of imlunestrant and abemaciclib provides maximal suppression in an ESR1 mutant cell line. And so we've recently seen this type of data put into practice with great success. There have been now a number of phase 3 trials, either reported or pending, that have looked at oral SERD combinations in metastatic disease. This includes, as we'll return to, EMBER-3 with imlunestrant. With giredestrant, there's actually 3 trials, as Nick mentioned, Persevera, Pioneera, and Avera. And with camizestrant, we have SERENA-4 and SERENA-6. So a very comprehensive program looking at these 3 oral SERDs in the phase 3 setting. So let's return to EMBER-3 for a moment. And as Joyce pointed out, this was a trial looking at imlunestrant monotherapy versus standard of care endocrine therapy versus the combination of imlunestrant and abemaciclib in a somewhat heterogeneous population of patients who had had 1 to 2 prior lines of endocrine therapy, including for some in the adjuvant setting, 60% with prior CDK4/6 inhibitor. And we saw that the signal for SERD activity was in the ESR1 mutant population, not so much in the ESR1 wild type population. But what about the combination arm? So this is the combination of abemaciclib and imlunestrant compared to imlunestrant monotherapy. In all patients, this was a positive comparison. We saw an improvement from 5.5 months to 10.9 months with a hazard ratio of 0.59. Focusing in on the patients who had CDK4/6 previously, this was still remained very valid with an improvement to 9.1 months. And I'll point out, and we'll get to this, that these are the best numbers we've seen yet in the story of oral SERDs. Most recently, we saw the subgroup analysis broken down by ESR1 mutation status. And what's very gratifying is that we can see the benefit of the combination of the SERD with the targeted partner, imlunestrant and abema, is seen in both patients with and without ESR1 mutations. Although you will note that in the presence of the ESR1 mutation, you can see the most profound activity with the hazard ratio 0.49. So it is possible that even in an ESR1 wild-type setting, the use of the two agents overcoming in a dual fashion resistance can overcome any dependence on the ESR1 mutation. Also returning to the topic of co-mutations, which we do talk about a lot, and we don't actually see it that much in clinic, but it is very important to talk about. Here we see for the co-mutation patients a substantial benefit to the combination of imlunestrant and abemaciclib with a PFS of 12 months. Now, in general, we think of oral SERDs as extremely well tolerated. We do know that imlunestrant can cause side effects, including some mild diarrhea and mild fatigue. These agents pair very well with targeted partners, but if we do see toxicity in a combination, it generally is coming from the targeted agent. And so we can see here when we add the abemaciclib, the rates of diarrhea, neutropenia, and fatigue are higher than they were with monotherapy. Not surprising. And in general, these are toxicities we are very familiar with. We know how to take care of them, and we can see that very few patients had to discontinue therapy due to side effects. Now, as Sarah just hinted, we did have this special surprise this year in 2026 with the listing of, the arrow's in the wrong place, imlunestrant and abemaciclib in NCCN. There is a footnote that suggests that this is preferred for patients with an ESR1 mutation who have not had prior CDK4/6 inhibitor. And then we've had some variable success getting access to this, but again, this is not officially FDA approved. Now let's turn to AVERA, which is a study that is very important because this is also looking at a combination of giredestrant and everolimus, but instead of comparing to an investigational monotherapy, this is comparing to a standard of care combination regimen of endocrine therapy with everolimus, a regimen that many of us may be using in clinic all the time. Patients who were eligible had had up to 2 prior lines of endocrine therapy. All the patients had prior CDK4/6 inhibitor, and the study had 2 co-primary endpoints looking at progression-free survival in the ESR1 mutant population and in the ITT population. The study was positive for both endpoints. This is for the ESR1 population. We can see an improvement up to about 10 months with the combination of giredestrant and everolimus, and also a significant improvement in the ITT population, an improvement up to 8.8 months. There was an exploratory subgroup analysis in the group of patients without ESR1 mutation detected, and this did not show a difference for progression-free survival, although there's a slight trend for overall survival. There was also an improvement in response rate and duration of response in this population. Back to co-mutations, again, we can see that in the setting of co-mutation, the oral SERD-based combination regimen was very active with prolongation in progression-free survival. We just a few weeks ago saw some updated data on toxicity. In AVERA, use of prophylactic steroid mouthwash, something that we definitely recommend with the use of everolimus, was strongly recommended but not mandated. About 60% of patients in AVERA did use steroid mouthwash, and for those patients, there was a prolongation in the time to onset of stomatitis. So patients were able to go longer without experiencing stomatitis, and for those who did, there were a few patients who required a dose reduction. One would think that if 100% of the patients in this trial had used prophylactic steroid mouthwash, the rates of stomatitis would be even better. I also want to point out that elacestrant has been looked at in combinations as well in the ELEVATE study, which is a platform study, phase 1/2, that has looked at elacestrant in combination with a number of targeted partners. Most recently at San Antonio, we saw data looking at the combination of elacestrant with everolimus on the left and elacestrant with abemaciclib on the right. In both settings, we've seen robust progression-free survival, 8.3 months on the left, 14.3 months on the right. I will point out, though, that these are not comparison studies, and there is a little heterogeneity in the patients who were accrued to each cohort, including prior exposure to CDK4/6 inhibitor. And I'm not going to belabor SERENA-6 as we previously talked about it, but just to remind people about meeting the primary endpoints of progression-free survival. We await the data on PFS2, which we will see on Tuesday, and we saw the profound improvements in quality of life. So I like to turn to this figure that was shown at ESMO last year, just thinking about the benefits of combining oral SERDs versus oral SERD monotherapy. Looking back at those Kaplan-Meier curves for monotherapy, we can see there's that steep drop-off with 60% of patients progressing in the first 6 months. These patients likely have endocrine-resistant disease, and the use of oral SERD monotherapy is unable to overcome this. In contrast, when we use oral SERD in combination with a targeted partner, this idea of attacking the cross-resistance, we can see now we have an early separation of the curves and a substantial improvement with the use of the combination. Now only about 30% of patients are progressing in the first 6 months. And we are consistently seeing progression-free survival numbers well above 6 months and really touching 10 months, which is the longest we've really seen in this setting. So we can see that oral SERD combinations co-target resistance pathways, can improve efficacy over oral SERD monotherapy. The excellent tolerance of oral SERDs allows safe combinations. We are awaiting the first FDA approval for an oral SERD combination, hopefully the Avera regimen of giredestrant and everolimus. And as we'll hear about in a bit, the role of oral SERDs in the first-line setting or even in the early-stage setting where there's less prevalence of ESR1 mutations remains less clear, but we definitely want to learn more.
Thanks so much, Erica. That was great. So we'll turn to a few questions. So regulatory and reimbursement issues aside, which treatment would you recommend for a 65-year-old woman with ER-positive, HER2-low metastatic breast cancer who progresses after letrozole ribo after 2 years? This patient has a ESR1 mutation and no PI3K pathway alteration. And here, in the setting of someone with minimally symptomatic bone mets, we do have a different approach than to the right, where we have someone who has visceral metastases. So maybe, Nick, I'll start with you. If you saw someone with minimally symptomatic bone mets after AI-CDK, it looks like you still wanted to use combination therapy here. Would you ever use an oral SERD? What makes you think of using combo here?
I mean, I think I would I would have a conversation with the patient about this choice, because I think, there is clearly a role for both, as we've seen in the answers to the questions. But generally, I'm quite worried about those patients, 40% who progress on a single agent endocrine therapy. So I generally would advise people to think about having the combination with everolimus. That, of course, brings more toxicity, but I'm convinced overall that the efficacy, once we have this combination approved, would be a good option for many patients.
But do you think, are there any clinical factors that would make you feel comfortable with oral SERD monotherapy ever? You're always going to use a combination.
I think these are the ones there. Well, this patient has got the ones which you would, yes.
Maybe.
Minimal bone disease, lymph node disease, disease which, if it rapidly progresses, isn't going to make the patient unwell, is definitely a patient group that is suitable for oral SERD, and we can see that in the votes here.
So it seems like most people are pretty clear that if someone has visceral metastases, that they want to do some type of combination therapy. I've heard a lot of mixed messages about people's comfort level with everolimus. I think there's some people who think, it's an old drug that's got a lot of side effects, I'm not going to use that drug. I don't know, Sarah, how do you feel about everolimus? Is it something you use a lot these days? Do you feel like it's tolerable? And how would you think about picking it now, an everolimus combo over a CDK beyond CDK combo?
I think we've gotten pretty good at managing the side effect profile of everolimus with the oral mouthwash, and we're just better at managing it. We when it first came out, we thought it was just a terrible drug, and then we met alpelisib, and we were like, wow. And then we got really good at everolimus. And so I really don't, I actually, patients of mine who have PIK3CA mutations who cannot tolerate capivasertib, or I'll switch them to everolimus because I just find it's easier to manage. Again, I don't think that imlunestrant and abemaciclib is the wrong choice here, but I don't have a lot of faith when I have another option that targets that PI3 kinase pathway, and everolimus hitting mTOR does appear to work and to help. It's an alternative pathway, and so that's why, I chose to go with everolimus, but I think that in the right patient, single-agent oral SERD would be appropriate, and in the right patient, doing imlunestrant and abemaciclib would certainly be something to discuss.
And Joyce, what dose do you start your everolimus at? I know this is highly controversial.
Yeah.
Obviously, the label is 10 milligrams, but is that what you're giving someone?
I don't tend to start at 10. I start healthy people without a lot of comorbidities at probably 7.5, and older gals with borderline end organ function and comorbidities at 5. And
then do you escalate? Or do you just keep them there?
I probably do escalate the from 5 to 7.5. Most people have some toxicity. I find this with the Abema story too. A lot of people end up having some tox, and so I don't end up going up. But because most people still have to manage the oral stomatitis, so I don't usually go up. I don't use 10 that much these days.
Well, Erica, you obviously ran the Avera study. One of the challenges that was seen with that trial was a discontinuation rate. What do you think about that, and is that something that you would experience yourself in clinic?
Yeah, so, I think that when you refer to everolimus as an old regimen, I think maybe it makes us feel old. I think we saw the Bolero 2 data. I mean, we saw the drug emerge and we used it, and then we figured out how to use it. We figured out how to manage the toxicity. And I feel like if people are struggling with toxicity now, it's because we have some newer agents that we moved to. We don't use it that much anymore. But when you get used to using it, it's really a pretty straightforward regimen to give, and especially when you get the right dose with the patient. I think right now, Avera began at 10 milligrams of everolimus, and that Kaplan-Meier curve I showed when the curve separates so early would make me a little hesitant to immediately start someone at 5, just because we don't know if we're going to miss that. But I do think that using the Swish study oral mouthwash, the steroid mouthwash, is so important. The Swish study really showed us that is a very helpful maneuver. And that I think that, with careful monitoring and with dose reduction if necessary and a lot of supportive care, we can keep patients on study. So I do actually think this is a really quite well-tolerated regimen when we have a close eye on patients and we use all the right supportive care.
So, Nick, would you ever use a combination strategy in someone who's ESR1 wild type?
With an oral SERD.
With an oral, so giredestrant, everolimus, or imlunestrant, abemaciclib. Would you give it if they're ESR1 wild type?
Would I like to? Would I be allowed to is a different question.
You could answer both.
Yeah, exactly. Would I like to? Yes. I would like to use giredestrant and everolimus because it's just more convenient for people than fulvestrant.
Do you think it's better, though? I guess.
No, I don't think. I think. Well, Erica showed the PFS curves. I don't think we can say it's better. It doesn't appear that it is, but I do think it would be more convenient for patients. So, if I was able to do it, I would do. And we're starting to use more everolimus again. When we first started using it, we didn't know how to use it, and we had exemestane and everolimus, which has a really poor response rate. But when we switched over to fulvestrant, and hopefully we'll then be able to switch over to giredestrant, the response rate's pretty reasonable. And so I think this is an old drug that's going to come back into more use.
How about you, Joyce? What do you think about the ESR1 wild type? Today we saw some data actually from Avera looking at PFS2, and it seemed like it's even a little better still in the ESR1 wild type. What do you think about that? Does that mean anything?
Yeah, I agree totally. I'd very much like to give it, and I hope that we'll be able to do it sometime. But I've actually never prescribed one of the oral SERDs in the ESR1 non-mutant population. I think it's... I just haven't felt confident we'd probably be able to get it for patients. But yeah, I mean, it would be great to not have to do the injections.
Yeah, I think most of us feel the SERDs are probably at least the same as fulvestrant in the ESR1 wild type, and just so much easier. And so I think it's definitely would be nice to have available, but just not clear it's actually better. So how would you indirectly compare the global efficacy of imlunestrant abema to giredestrant everolimus in the pretreated hormone receptor positive patient? Here, most people say about the same, but Joyce, you think imlunestrant abema is a little bit better. I'm curious, because I do find this is a challenging decision to make if both had approvals. How would you pick between imlu abema and giredestrant everolimus?
The data are pretty similar. This is an ESR1. In the wild type population, the data are not that dissimilar. But I think that the was not 9. I remember forgetting. I looked up the numbers at the time, but I think it's about 9 months for the combination in the wild type for this combination, and 5 something or 5 something, 5.5 in the wild type with the giredestrant everolimus. So I think that's where I was coming from.
Okay. And so how would you pick between the two regimens just in general? If you had someone who was, let's say, ESR1 mutant, how are you picking between mTOR inhibition or abema post-CDK?
So if somebody, if a woman does not do particularly well with palbo or ribo, she doesn't even get like a year or something, I will give her abemaciclib. And if she's got an ESR1, I'll give her imlunestrant, because I have found that I can, in some patients, in a subset of patients, I can get them a durable response sometimes, So I will keep at the CDK for a while, as long as, she's doing okay and doesn't need chemotherapy. But the giredestrant everolimus, once I felt like I was not going to get any more mileage out of the CDK, that's when I would use that.
Technically, would anyone ever sequence them?
Yeah,
right?
Yes, imlunestrant abema followed by the giredestrant.
Yeah, you would just
no question. Yeah,
SERD but with SERD after SERD.
Oh yes, I think we're going to absolutely do that. No, I think that's how it's going to go. Yeah,
not as single agent necessarily.
Yeah,
I think
but combo,
doublet
you do
with
it.
different mechanisms of action with the partner.
That's interesting. If imlu abema were available today, for which type of patients would you most likely employ it? And I think we covered this. I think most people feel like they would probably use it in ESR1 mutant disease, but if it was available, would think about the wild type patients just because of convenience. If giredestrant everolimus were available, for which types of patients with hormone receptor positive disease would you most likely use it? And here again, I think similar situation, ESR1 mutant. Here I think we're usually making some decisions based on visceral metastases, tolerability in the individual patient. So it would be nice to have both of these options available. So I think one of the things we didn't touch on yet was so well is the double mutant patients and the PI3K pathway options. And so I think we'll dig into this a little bit more after Sarah's presentation.
Excellent. Thank you. So I won't belabor this. You've seen this pathway, but up to 70% of breast cancers do have an alteration in this pathway, and we know that it's associated with prognosis. We have a growing number of agents that target the PI3 kinase pathway. Alpelisib and inavolisib target are alpha selective for PI3 kinase. Gedatolisib is a pan PI3 kinase inhibitor and also inhibits mTORC1 and mTORC2, and everolimus inhibits mTORC1. So we have phase 3 data that have addressed targeting PIK3CA mutated breast cancer and endocrine-resistant disease in particular. Of course, the first came from the SOLAR-1 phase 3 clinical trial, 572 patients assigned to alpelisib with fulvestrant versus fulvestrant alone. And the progression-free survival was significantly better, on the order of 5 months. Overall survival was not better, and we did have have to manage a number of PI3 kinase inhibition associated toxicities as well. It's important to note only 6% of patients in this study had received a prior CDK4/6 inhibitor, so this isn't really reflecting the patient population where we'd be using one of these agents today in the resistant setting. Capitello 291 looked at capivasertib, an AKT inhibitor, in combination with fulvestrant against fulvestrant alone. I would just call out both of these studies were comparing to single-agent fulvestrant, which I think is going to be a thing of the past. And in this particular study, prior CDK4/6 inhibitors were allowed, and they wanted more than half of patients, at least 51% of patients who had this. And in this study, 2/3 of patients had received a prior CDK4/6 inhibitor. 40% of patients had a PI3 kinase pathway alteration. It did not require PIK3CA mutation. The study did meet its primary endpoint of showing an improvement in PFS in the PI3 kinase pathway altered and the intent to treat, as you can see on the top there. The PI3 kinase pathway altered median PFS was 7.3 months compared to 3.1 months, and 70% of patients had received a prior CDK4/6 inhibitor, so it's now reflecting more of our modern-day patient population. This was approved in the U.S. in 2023 for those patients with the PI3 kinase pathway alteration, not specifically PIK3CA. And you can see the outcome for patients in the red box who had received a prior CDK4/6 inhibitor looks quite similar compared to those who had not. Overall survival was not significantly improved. There was a trend toward improvement that didn't meet pre-specified endpoint in the altered population. Numerically, you can see the numbers there in terms of median overall survival. And in the overall population, this was not formally tested, given that it wasn't met in the altered population. But again, no difference between that. And then the safety concerns are the same as we see with PI3 kinase pathway inhibitors: GI side effects, rash, hyperglycemia, although the hyperglycemia rates were lower than we've seen with alpelisib, and some stomatitis. And so this is a table now. On the far right, we're not talking about Inavo because this technically was a first-line study, and I'm focusing on patients who are pre-treated, but just looking at SOLAR-1 and Capitello, you can see the various entry criteria in terms of HbA1c, prior CDK4/6 inhibitor, and the outcomes as well as toxicities. Now, what about phase 3 trials that enrolled patients of PI3 kinase pathway inhibition in PI3 kinase altered or non-altered disease? Everolimus has shown efficacy regardless of PI3 kinase pathway alteration in the Bolero study, keeping in mind none of the patients enrolled had received a prior CDK4/6 inhibitor, and in this population, the median PFS was 10.6 months for the doublet. We know that the benefit of everolimus on the left side there is really regardless of whether or not the patient's tumors had a PI3 kinase pathway alteration. And so mTOR inhibition may have more activity because it is mTOR has many nodes of input that are not just the PI3 kinase pathway. So perhaps inhibiting it lower in the pathway is leading to benefits that are outside of just those tumors that have an altered PI3 kinase or AKT. What about triplet pathway inhibition? Nick talked earlier about the benefits of combining 3 agents, Inavo 120, and of course a lot of preclinical data suggesting support for this, but toxicity has been problematic until Inavo 120 came along. There was a phase 1b study done looking at gedatolisib, the PI3 kinase, pan-PI3 kinase mTOR 1 and 2 inhibitor in patients. Now, a small study, 27 patients, but gedatolisib was combined with palbociclib and fulvestrant, led to an objective response rate in 56% of patients and a PFS of over a year. Needless to say, these were very interesting and compelling data that led to a larger phase 3 confirmatory trial. And you can see the objective response rate was seen regardless of PIK3CA mutation status. Again, another interesting and compelling detail. So this led to the Victoria-1 study, which is shown here. The upper part of the study is known as Study 1, and this is in patients who had PIK3CA wild-type tumors. So to get on Victoria-1, patients had to have central testing for PIK3CA mutation. If they didn't have the mutation in the tumor, they went into Study 1, and if they did, they went into Study 2. Study 1 allowed patients who had received prior CDK4/6 inhibitor and an AI, and up to 2 prior lines of endocrine therapy, but no PI3 kinase pathway inhibitor, no prior chemo. And patients received either a triplet of gedatolisib palbofulvestrant, a doublet of gedatolisib fulvestrant, or fulvestrant as a single agent. There was crossover allowed from the single agent arm at the time of progression, and the primary endpoint was PFS. And these are the results that were published earlier this year. The triplet was better than single agent with a median PFS of 9.3 months compared to 2 months. And the doublet was also better compared to single agent fulvestrant, 7.4 months versus 2 months. Both were statistically significant. These forest plots shown side by side show the subgroup analysis, and really all subgroups receiving the triplet benefited. Didn't matter in terms of age, menopausal status, etc. But in the doublet versus single-agent fulvestrant, you do see that maybe patients whose disease progressed more quickly on a CDK4/6 inhibitor or had other high-risk features, visceral disease, maybe they weren't benefiting as much. So if we have both of these approved, maybe we'll be selecting the triplet, and that'd be an interesting thing to talk about a little bit later. High-risk features may compel us to choose the triplet over the doublet. Survival wasn't mature. There was a trend in the direction supporting gedatolisib, but further follow-up is necessary. And adverse event profile of this intravenously delivered PAM inhibitor were different. Now, you did see more stomatitis. 2/3 of patients had any grade stomatitis in the triplet and over half in the doublet. But interestingly, we're seeing less rash, less diarrhea, and less hyperglycemia. Only 9 to 10% of patients having hyperglycemia, which is really interesting for a PAM inhibitor. Now, the Victoria-1 Study 2, I can't present to you, but it'll be presented on Tuesday. And these are the results of the clinical trial shown here. This is the Study 2 design for those patients with a PIK3CA mutation, a triplet again, a doublet of gedatolisib fulvestrant, or a doublet of standard of care alpelisib fulvestrant, and patients were randomized in a 3:1:3 fashion. So stay tuned on Tuesday for these results, and we'll talk about it at next Research to Practice. And just to summarize safety, I think we've talked a lot about safety tonight, and this just sort of summarizes overall the safety of inavolisib, alpelisib, capivasertib, ipatasertib from the finer study I'll show you in a moment, and gedatolisib, and there are clear differences highlighted in red. And then just a final word on ipatasertib. This was a study that was done in patients with stage 4 breast cancer who'd had a prior line of CDK4/6 inhibitor. They had cfDNA done for stratification and were randomly assigned to IPAT plus fulvestrant or fulvestrant alone, with PFS as the primary endpoint. And you can see the PFS was significantly improved, 5.3 months versus 1.94 months with ipatasertib. So interesting data, again, seeing pretty good benefits in most of the subgroups except for those patients with a poorer performance status, and more is certain to come. So in summary, PIK3CA mutated, we have alpelisib plus fulvestrant and capivasertib plus fulvestrant in patients who are CDK4/6 inhibitor pretreated. For patients with or without a PI3 kinase alteration, we have a number of options potentially coming soon.
Oh, thank you very much, Sarah. I think this would make things a lot more complicated for us in terms of choices. So we will have a lot to dig into. So we'll turn to some of the survey questions and we'll get into some of the nuances. So which treatment would you likely recommend for a 65-year-old woman with ER-positive, HER2-low who develops minimally symptomatic bone mets after getting AI ribo? And this is a patient who now has a PI3K mutation. So here you can see across the board, if someone had been on AI CDK for more than 2 years, people feel pretty comfortable with fulvestrant, capivasertib, but that's the same for someone who, was on their CDK for a shorter period of time. Most people are giving capi. Joyce, it sounds like you might consider CDK post-CDK.
Yeah, because if they don't get at least a year, I want to give them another option. If they had Pabo or Ribo up front, I give them a BEMA to see if I can get some non-cross-resistant benefit. I want to exhaust my CDKs before I go on to the next class of agent.
And so if you were to give them, let's say, fulvestrant or BEMA second line and they progress, are you going to, one of the audience members asked, do you recycle your fulvestrant if you were going to try and do fulvestrant capi?
Yes.
Or what would you do
in that
situation?
Would. Uh-huh.
Yeah. And so which treatment would you recommend for a 65-year-old ER-positive, HER2-low, develops minimally symptomatic bone mets after getting AI ribo for 2 years and now has a double mutation, so ESR1 and PI3K mutant? Here it looks like people are still preferring the PI3K pathway inhibitor with capivasertib, but a few thinking about SERD monotherapy. Again, this patient does have minimally symptomatic bone mets, and so I think that's probably where the hinge is coming from. Erica, how would you think about this patient?
So I think, we've seen data that in the setting of dual mutations, targeting either mutation, either PIK3CA or ESR1 can be very active and can provide benefit. So I think a lot of this becomes patient decision-making. Is the patient symptomatic? What's the duration of prior therapy? What is the patient preference in terms of side effect profile? And I think some of that information can inform this decision. For me personally, I do fear the PI3 kinase mutation, and I do think that this really represents a significant element of endocrine resistance. So I want to treat that patient with some sort of doublet. So if I'm choosing between capi-fulvestrant versus oral SERD monotherapy, I would be leaning towards the doublet regimen here, unless the patient was like the one we saw before, older, poor performance status, where perhaps the monotherapy would be better tolerated. But if I was picking between capi-fulvestrant versus a SERD combination, using SERD with a agent targeting PI3 kinase pathway, then that would be a very compelling decision.
So, given that you said that, have you actually ever prescribed elacestrant plus capivasertib, and would you do that?
I have not. Have you?
I actually have, and it got paid for, which was interesting. So actually at this meeting, there is data that was presented from the Elevate trial that looked at the combination of elacestrant plus capivasertib. The Elevate trial was had multi-arms. It was looking at safety of combining elacestrant with multiple different targeted agents. And so one of the arms did explore combining elacestrant with capivasertib in patients who had a PI3K pathway alteration. It was a small group. It was like 31 patients in the phase 1 component. Everyone was post-CDK. They did find the recommended phase 2 dose to be the full dose of elacestrant, but with capivasertib at 7.5 milligrams. It wasn't that there was any drug-drug interaction between the two. It was just at the full dose of capi, at the 400 of capi BID, they did see some grade 3 rash, which to be honest isn't atypical for capivasertib. You still can't see that, but at 7.5, at 320 of the capivasertib, that's when they saw that there was not high-grade rash, and so that was the recommended phase 2 dose. And so they've now completed accrual to a single-arm phase 2 portion of elacestrant capivasertib, so they're just waiting on follow-up data. But, I think these are the challenges. This is single-arm data. It's not some randomized trial. It's It's not like it's in the NCCN guidelines or anything yet, but we have been finding that, it does seem like insurance, it has, maybe not in Washington, but in other states, we've been seeing it getting covered. So I think it just goes to show that I think we would love to have an oral SERD with a PI3K pathway inhibitor. We just don't have one right now. So, I think this one becomes a little tough, truthfully.
I would probably be comfortable giving giredestrant with everolimus in that particular patient, if it were approved, because it does work, and it's agnostic to PI3 kinase mutation status. And maybe we'll have gedatolisib available, after the presentation. So it is becoming an interesting, we were confined to certain options in this question, but it's not as simple as even the table shows.
I mean, it's a good point that in truth, everolimus does have activity in a PI3K pathway mutant or wild type patient, and so I think that's fair. I guess, given you just mentioned gedatolisib, if it were available, how do you think about it in the setting of it being an IV drug that does require coming in 3 times in a month, right? Weekly, 3 out of 4 weeks. It still does have some toxicity, right? We saw, over a 60% rate of stomatitis. We did see almost a 30% rate of rash, so it wasn't completely rash-free either. And so how do you make a distinction between thinking about using something like capivasertib or gedatolisib? I realize we haven't seen the data yet for the PI3K mutant, but just thinking about toxicity profiles.
Yeah, I haven't. I'm not so convinced that the IV formulation is going to be as problematic as we think. Our patients come in frequently when they're dealing with metastatic disease. It'd be great if it was all oral and we could keep them out of the infusion room, but I think that the rates of diarrhea, the rates of hyperglycemia, as low as they are, I think they're pretty compelling. So when I have a number of PI3 kinase pathway inhibitors at my disposal, I want to use the one that's least toxic to the patient. And I think the experience I've had with rash with capivasertib and having to transition multiple patients to everolimus, it's problematic. And the hyperglycemia and the reports of ketoacidosis coming out with other ones, these are real issues.
I mean, it's true now with capivasertib, we have to do glucometer teaching. We have to teach them how to do finger sticks at home. People can have diarrhea and need loperamide. So certainly it's not toxicity free. We've seen in the post-CDK setting, Capi has, about 5.5 months in a PI3K altered patient. So I guess, Joyce, if you're looking to see what the data may show on Tuesday when Sarah presents the PI3K mutant data for gedatolisib, what level of benefit do you think you need to see? What kind of PFS do you need to see to say that you'll switch from using an oral drug like capivasertib in a PI3K pathway altered person to switching over to using geda in some of the PI3K mutation?
If it comes in about 10 months or so, something like that, I think that will be very compelling. I still may use, though, in somebody with relatively asymptomatic bone mets, I still may go the oral therapy route and save the IV for later. I think we're going to sequence these as well, honestly.
By oral therapy,
like a capi fulvestrant or capi elacestrant, if I could get it, I think I will stay with oral inhibitors of the PAM pathway, including, giredestrant, everolimus. I'm going to sequence these things, and but the IV therapy, if somebody were sicker with more symptomatic disease, heavier tumor burden, then I would be wanting to go for the regimen that would get the best PFS up front for the patient. So
you feel comfortable, though, sequencing one PI3K pathway inhibitor after another?
I do. And we just simply don't know what the right way to go is. But if you inhibit AKT, for example, you've got a PIK3CA and you inhibit AKT, you may get upregulation of that clone that has a PIK3CA mutation. So it may be still very, very much driving the cancer. So it makes a lot of sense to go after that PIK3CA at that time. What's nice about gedatolisib, of course, it gets PIK3CA and TORC1, TORC2. I mean, it's a real shutdown of that pathway. So, going after PIK3CA with an AKT inhibitor may not end up being the most effective way to go, right? But I find the tolerability generally quite good with that combination. So if somebody's minimally symptomatic from their disease, I try to hold off on as much toxicity as I can for as long as I can.
How about Nick? I guess one question to you: do you think PI3K pathway inhibitors will work one after another? Do you think there's any potential for doing that, whether it's doing everolimus, capi, or capi, geta? Do you think there's a role for that?
Well, we've got very good data on everolimus from the very old studies of buparlisib that were done 10 years ago, a PI3 kinase inhibitor that never got licensed. And they did 2 separate studies, one that mandated prior everolimus, one with none, and the PI3 kinase inhibitor buparlisib had equal activity in both. So I think we can draw conclusions that it's likely that PI3 kinase and everolimus inavolisib and perhaps capivasertib are going to have activity one after the other. Whether that's the same with gedatolisib, I don't know, because that's a different kind of drug. Yeah. But from those studies, I think we definitely should feel relatively confident using everolimus after inavolisib or capivasertib and the other way around, whilst we're sort of building more data.
That was in PIK3CA mutant patients.
Yeah, it was in PIK3CA mutant patients. One was done with prior everolimus, one without. Mm-hmm. Because the drug was never licensed because of toxicity, the studies have faded away a little bit in our memory, but the results were clear.
There was a recent publication that just came out from the Memorial Group where they actually looked at people who sequenced alpelisib and everolimus, and they looked at the PFS, and it wasn't so great with second agent. It went after the numbers are small when you start slicing and dicing. So I think this does remain like an open question. I mean, it's interesting about the buparlisib data. So I think we're going to have to see more, right? I guess, Erica, what do you think about the IV issue with gedatolisib? Is it going to impact your preference for utilization?
I think it's tricky. One of the really nice things about that part of care when patients are receiving endocrine-based therapies is that they're kind of free from clinic, and we have many patients who are working full-time and taking care of their families, and having to come in for the visits definitely, has a very big impact on their ability to do all of those things. That being said, in a patient who has high-risk disease, symptomatic disease, substantial risk of disease progression, it may be necessary and worthwhile in order to get a highly active regimen. So I don't necessarily think this is a regimen that all of our patients will be able to get, as I do think it would have too much impact on their kind of life trajectory in that manner. But there is definitely a group of patients for whom it will be worthwhile to spend time with us in clinic.
Maybe we'll turn to this next question. So regulatory and reimbursement issues aside, which treatment would you recommend for a 65-year-old who has minimally symptomatic bone mets after AI ribo if they have no pathway alteration, no PI3K or ESR1? So here, Sarah maybe has a little bit of preference to geta in this setting. I think this one is a tough one because now we have a lot of choices, right? You could give a triplet, fulvestrant, palbo, geta. You could give a doublet, actually as well, fulvestrant, geta. You could give fulvestrant, abema, some endocrine therapy, everolimus. And so I will say I think this is where I'm struggling a bit in terms of how to think. Well, maybe first I'll ask the first question is, Sarah, how do you decide between a triplet or doublet, given the data that you've shown with fulvestrant, palbo, geta? What do you think the difference is between giving fulvestrant, geta or fulvestrant, palbo, geta?
Yeah, I mean, I have to admit, this is a long survey, even though when they emailed it, they said this is a short survey.
Yeah, they Sarah. You're exactly
There
right.
may have been some surveys. But because I think the doublet, I think I missed the minimally symptomatic part. I think the doublet would have been, and that 2-year sort of benefit from frontline CDK4/6 inhibitor. This may be a patient where the doublet would be perfectly appropriate to reduce the risk of stomatitis because the palbociclib does increase the risk of GI side effects and stomatitis. But it remains to be seen if both are going to be approved. We'll have to see.
Yeah. So if both were approved, it sounds like your preference is minimally symptomatic doublet, maybe more visceral disease, high-risk features, triplet. Is that right?
Yes.
And then if you're prescribing it, just assuming this is going to get approval, what would you recommend for prophylactic therapy?
Definitely the oral steroid mouthwash, although the patients were mandated to do that, and this still was there. So although it does drop off after the first few cycles, so it's something that is getting better, and I think it does get better with good oral care, but it's not your typical everolimus type stomatitis. And in terms of non-sedating antihistamine it wasn't mandated in this study, but I think it is important to give in the beginning to mitigate that.
And do you need to do anything to monitor hyperglycemia? Again, the rate was low. And I guess they're probably getting a blood draw 3 out of 4 weeks anyway. So you'll be checking glucose pretty routinely.
Yeah, it's pretty non-problematic. I mean, it really stands out to not have. And I'd like to see future studies really push the envelope here in terms of HbA1c and can we have diabetics treated with this agent, because this really is a distinguishing feature of gedatolisib, that and the GI tox.
Would anyone else on the panel use gedatolisib in someone without a pathway alteration?
You go ahead. Yeah.
Well, I think in this situation, the patient was stable on their first-line CDK4/6 regimen for 2 years. They are minimally symptomatic. So, for me, this was like the perfect post-monarch patient. I wouldn't be necessarily thinking about triplet in this situation. But if we changed the case and made the patient more symptomatic, then I would be much more interested here.
So if they had visceral mets, it sounds like then you'd be pulling the trigger potentially to get a
symptomatic disease.
Disease, yeah. And what if we twist it and say they have an ESR1 mutation now and visceral disease? What are you going to do? Are you going to give them geda with fulvestrant, or are you going to do giredestrant everolimus?
Giredestrant everolimus.
Yeah, you too, Sarah, you would?
Yeah.
So it sounds like the preference for geda is ESR1 wild type if you don't have a PI3K pathway alteration. Is that correct? And probably more aggressive disease, not probably minimally symptomatic. Mm-hmm. Is that fair? Mm-hmm. So one of the people in the audience asked, we talked about combining, for example, Imlu, Abema. Would anyone ever combine giredestrant with a CDK in a post-CDK setting?
I think we probably wouldn't have good luck. The reason we're getting Imlu Abema because it's on NCCN is useful in certain circumstances. I think reimbursement could be tough. Yeah. I wouldn't object to it if there was a problem with imlunestrant, but I'm not sure there'd be an advantage.
Yeah, I would agree with that. So here, the next question: 65-year-old ER-positive HER2-low has metastatic disease after 2 years of adjuvant anastrozole, receives fulvestrant ribo for 2 years, followed by disease progression. This patient now does not have any alteration in a pathway. And so here, I think this is where what we just covered, I think, comes out, that the minimally symptomatic patient, people will choose different options, but probably in the setting of more visceral metastases, then gedatolisib starts to come out there. Nick, you turned to TDXD, which is, I think, also a good point, is how do you know when to pull the trigger to go to an ADC?
Yeah, I mean, maybe I forgot when I was answering this. Maybe I forgot that we were talking about oral SERDs and PI3 kinase pathways in this. I think I was thinking here, if someone had it says normal LFTs, certainly clearly if they had abnormal LFTs, this is the kind of patient that I would be thinking about trastuzumab deruxtecan. With normal LFTs, I think I'd agree with the panel. This is one way you would still try and avoid going to trastuzumab deruxtecan.
I think we covered this. So I think our preferences with the PI3K mutant pathway may change after we see the data Sara presents, where we will have to think about what we're going to do with choice of gedatolisib for a PI3K mutant patient or CAPI. And so I think more to come post Tuesday on the PI3K mutant patients. For the sake of time, I'm going to skip ahead, and we're going to turn to the use of oral SERDs in the early disease setting. So we just saw some recent data, both at San Antonio and then now at ASCO, covering the lidERA trial. So this is really, I think, a change in landscape for our patients with early-stage ER-positive disease. So certainly we just covered all the various forms of inhibiting the endocrine pathway. And we do know there are several trials trying to use SERDs in the early disease setting. So there's some trials that focused on using SERDs in the upfront adjuvant setting, and there's some trials that focused on a more of a sequencing strategy. So the lidERA trial was one that looked at the upfront adjuvant setting, really looking at a SERD as monotherapy, in this case giredestrant. The Cambria-2 study is just about to complete accrual, and it looked at giving camizestrant in the upfront adjuvant setting, but did have a cohort of patients, 30% of patients who could get cami plus abema in this setting, and that compared it to endocrine therapy. And so we've seen data now from the lidERA trial. So again, this was a study for upfront giredestrant compared to standard of care endocrine therapy. But here, the category of patients that was enrolled was kind of a mixture of patients, some that I would count as intermediate risk and some that I would consider as high risk. So they did allow some stage 1 patients, so you could have a tumor over a centimeter and be node negative if you had high risk features. Otherwise, you had to have a T4 tumor or you had to be node positive. And then patients got randomized to giredestrant for at least 5 years or standard of care endocrine therapy. Do note that if a patient is premenopausal, they are mandated to get ovarian suppression with their giredestrant. And the vast majority of patients who are premenopausal actually also did get ovarian suppression in the control arm. And so this is just a review of the way they categorized risk. So they stratified patients by being medium risk or high risk. And the high risk patients kind of fit into what I would think of as a monarch E type population, so a very high risk group of patients. And so what we saw from this trial was that they did tend to enroll patients that were a mixture. So we actually saw more data today that broke out the premenopausal and postmenopausal, but it was about a 40-60 split of pre and post. About 12% of patients had stage 1 disease, 20% were node negative. And you can see that the majority of patients fell into the high risk category. Only 30% fell into the medium risk category. And in terms of prior chemotherapy, about 80% had prior chemo, which certainly makes sense given the vast majority had a pretty high-risk disease. And I will just say I was very surprised when these data were presented because at a very early time point with just a little over 30 months of follow-up, they saw a 30% reduction in IDFS events. So that was quite striking and actually very much in line with what we saw from early presentations of the adjuvant CDK4/6 inhibition. We also saw about a 30% reduction risk of recurrence at about a 3-year time point. So I think quite striking, absolute benefit, almost a 3% absolute delta between the two arms. And, I think there's some who have argued, well, maybe a lot of this was driven by the tamoxifen-treated patients. And certainly the benefit is larger in the TAM pretreated patients, but it is a small proportion of the patients in this trial. So I don't think it's probably driving the majority of this benefit. But you can see that the events are really being driven by the higher risk patients where you're not seeing quite as much benefit. For example, in stage 1 patients, that confidence interval is very wide, but the point estimate does kind of hover around 1, where you do see a clear benefit in the stage 2/3 patients. And so clearly that must be driving, at least at this early time point, the majority of events that we're seeing. But most of these events are distant events. So you're seeing a 31% reduction in the risk of developing a metastatic recurrence. Survival data is highly immature here, so I would just take this with a grain of salt, but at least you're not seeing any detriment and at least a trend to suggest that we maybe in the future could see some difference. Overall, I would say I think most of us felt these data were generally very good in terms of safety, well tolerated, really not a lot of grade 3, 4 adverse events, and not really any different between the two arms. The rate of discontinuation from treatment was pretty low. I think what we were hoping to see was a difference in the rate of arthralgias. Obviously, AI arthralgias are a major problem for us, and overall the rate looked similar. But when you look at discontinuations due to arthralgias, you do see it's about half. So I think that is reassuring that maybe, it's not that these arthralgias are quite as bothersome. And I think this is a pretty tough toxicity to tease out with CTCAE. You do get bradycardia with giredestrant, so something to be aware of, but the vast majority of this is low-grade asymptomatic bradycardia. Today we did see some data also by menopausal status, again confirming that the benefit is seen both in the pre- and postmenopausal patients, with even larger benefits seen in the premenopausal population. So I think very reassuring that this benefit was seen across all patients. So I think clearly this data is very striking, but it is early. And it does leave us with a lot of questions that I'm sure we will turn to. But there was no CDK that was given with concurrent administration of giredestrant. And obviously now we have survival benefit from the Monarchy study in our high-risk patients. So it does leave us with this conundrum that if giredestrant is approved, who are we actually going to use it in? And so I will definitely turn to our panel to get their thoughts on that shortly. And then I think we're going to have to see what the future holds, because the Cambria-2 study, again, is just completing accrual, but also looked at upfront SERD in this setting. It was camizestrant compared to endocrine therapy, but again, did allow concurrent utilization, though that concurrent utilization was capped at 30% of the population. So we'll definitely ask the group what they would think if this study were to be positive and how that may change their perspective. But we also have a bunch of switching trials that have been done and some that are continuing to enroll. So these trials are really taking the idea that patients can get their upfront endocrine therapy for 2 to 5 years and then switch over to a SERD and be on that SERD for 5 years and look to see if there are differences in IDFS. This does require that patients, if they got an upfront adjuvant CDK, have completed their CDK before they go on to a switching trial. The EMBER-4 study actually was amended to enroll over 8,000 patients, which is really quite striking to me, and was able to enroll this in a pretty rapid manner. And so we are awaiting data from this switching trial that looked at imlunestrant compared to standard endocrine therapy. The ELEGANT trial is currently enrolling and will likely complete accrual this year. This study is looking at high-risk patients, so in essence predominantly node-positive patients, very similar to a Monarchy-type population, comparing elacestrant to standard endocrine therapy. And then there's a Cambria-1 study, also a switching trial here, looking at camizestrant compared to endocrine treatment, and this study has completed accrual. So you can see that there are a number of these trials that will, I think, change our landscape in the very near future. There's a novel study, I think, that, is based on MRD, so it's taking patients who have ctDNA detection and then randomizing them to get elacestrant or endocrine therapy. So this will be, I think, very interesting and something that is pretty innovative. So now thinking about the giredestrant data, clearly our panelists all would love to have access to giredestrant for our patients. I think people were impressed by the data. But I think the bigger question is, who are you actually going to give it to, particularly knowing that the approval would not be with a CDK4/6 inhibitor? So maybe, Nick, I'll start with you. What would you do if giredestrant was approved? Who are you actually going to use it in?
Yeah, so I don't think I can look past the monarchy data with abemaciclib for higher risk patients, where we've seen the overall survival benefit and we've seen the duration of follow-up. So when I'm looking at where I'm thinking of using giredestrant, it's not going to be in those higher risk stage 3 patients, where I think I'll continue using abemaciclib. But in the lower risk stage 2 patients, where most of them are cured, of course, anyway, and the added benefit of these drugs is relatively small, there I actually think, even though the follow-up's relatively short, I'm much more attracted to giredestrant because of its side effect profile, the ease of giving it compared to 3 years of ribociclib. And so in those stage 2 patients, assuming giredestrant gets a license, that's where I'm thinking I will be wanting to use it.
How about you, Joyce?
So I think there'll be a large cohort of patients who cannot tolerate their AIs and who will need another option. Many of them will be on their CDKs. I think there's going to be a big use of giredestrant in that population. They're actually starting a study to look at that intolerant population, and like we're all of us investigators are running for the door trying to get on that trial. I mean, it's a big problem we have in the in clinic. So I think there'll be a lot of use of that. You know, we're waiting to see some safety data with giredestrant and abemaciclib from the lidERA trial. Cambria 2 is looking at a 30% cohort with CDK4/6, so there'll be data coming out there too. So I think increasingly we're going to be comfortable, and maybe we'll get a footnote in the NCCN guidelines that, you know, definitely for intolerant patients, for sure. For the lower end of the risk, patients that are not eligible for CDK4/6 inhibitors, I tend to use ribo for the NATALEE population. I tend to use abema for the monarchy population. But there still is a group, a small group, that was eligible, even though you showed the point estimate wasn't particularly persuasive at this moment, at least for the stage 1. I still think I'd be inclined to do that, because that was a pretty high-risk stage 1 population, to a pretty high-risk node-negative population. I do think that the switching data will probably be positive, the trials, and I think they'll be reporting out not too far in the future. And so I wouldn't do that now if giredestrant. I would not do that without data, but I think in the future we'll be able to switch after 3 years of CDK4/6.
How about you, Erica? Would you use giredestrant in the T1C N0 patients if it were available?
Yeah, so I think, as Joyce pointed out, the stage 1 patients who were eligible for lidERA were high-risk patients. In my mind, I'm thinking of a premenopausal patient with a T1C N1 MYC cancer, so a stage 1B. Grade 3 oncotype is 40. I'm worried about that patient. I've already given her chemotherapy. I'm giving her extended duration adjuvant endocrine therapy. But she's not a candidate for a CDK4/6 inhibitor. So I want to give her something else. So in that setting, you know, I would consider, instead of AI, offering that patient giredestrant. And I would point out, because she's premenopausal, she would have to take it with LHRH agonist, because we must use that when we give oral SERDs. So I do think there are select patients who would be great candidates for adjuvant giredestrant, but it is not at all something for all stage 1 patients. And I think we just have to think carefully about the lower stage patients who overall have a favorable prognosis before we decide to use it.
And then Sarah.
Well, I think the way I looked at this question is, yes, I think we'd all agree we should be using CDK4/6 inhibitors and not in combination with giredestrant in our higher risk patients. But adherence to therapy is critical for our patients with high-risk disease. And I have patients lined up waiting for giredestrant to be approved because they want something that will relieve them from the arthralgias. So this is where I would practice the art of medicine, and after completing the CDK4/6 inhibitor, would be very comfortable putting them on giredestrant. I think fulvestrant is probably better than aromatase inhibitors and tamoxifen. It just was never studied in early stage disease. So we're seeing that here with giredestrant. I'm not thinking that it's not going to be effective. In fact, it may be more effective in those high-risk patients. So I'd be very comfortable starting it after the end of CDK4/6 inhibitor.
So if you had a monarchy patient and you give them AI abema, and we don't have switching data available, and they are not intolerant to their AI, and giredestrant's available, are you switching them?
I wouldn't necessarily proactively do it in that situation, but by the time that happens now for our patients, we'll probably have more data to inform it. Do I think it might be more effective? Yes, I do.
Would you give Bema if you could get it paid for and they had their safety data presented? Just with single-arm data, no randomization?
I would be uncomfortable with that until we have more data, I think, the combination.
So do you think we need randomized data to prescribe SERD CDK in the upfront setting?
In the curative setting, I'm more cautious about toxicity and long-term toxicity. In the metastatic setting, I think there's more freedom to operate because we're dealing with an incurable disease. But here, I think we have to make sure we have all the data in hand.
So let's say we have a crystal ball, and let's pretend Cambria 2 reports, and let's say it's a positive study, and their benefit is seen in the ITT population. They only have 30% getting concurrent abema, but there's a trend suggesting there's benefit also in the concurrent abema. Are we going to just start giving cami-abema to the majority of people?
If they're high risk, I would.
Yeah, you would. Mm-hmm. So it sounds like most people want to give SERD.
Yeah.
So then will no one be switching people because everyone's just going to be starting SERD CDK from the get-go and they're just going to keep people on SERDs for 7 years? Maybe. Nick?
Not sure I have an answer to that question. One thing I was just going to pick up on, I mean, we've talked about arthralgias. Obviously, vaginal health and sexual health is really a big issue on AIs. And the oral SERDs and the ability to confidently be able to use vaginal estrogens is another thing that I think will be another reason where we'll be wanting to use oral SERDs as opposed to AIs in those younger women who have real problems. And so that's another reason that I'm looking forward to giredestrant being available, because of course we all worry about using vaginal estrogens with someone on an AI and spillover effects of the estradiol that just aren't a problem when you're on an oral SERD.
So certainly arthralgias, vaginal health issues. What do you think the impact of bone health will be from these drugs? Obviously, we all struggle with osteoporosis that can develop on the AIs. Any thoughts on whether these drugs may be better for the bones? Joyce?
I think Elegant is doing a bone study because it's got a little SERM activity. It's mostly an antagonist at the doses we use in clinic, but there may be a little bit of SERM activity, so they're studying bone. But otherwise, I don't think they're going to be great on bones. I don't think so with the destruction of the estrogen receptor.
Yeah, this will be an important toxicity signal to pay attention to as these trials report.
Mm-hmm.
So we have seen a press release from Persevera, and we will see the data on Tuesday. It suggested that SERD CDK is not better than AI CDK in the upfront setting, and yet we all kind of just said we'd want to give AI CDK upfront, SERD CDK upfront. Are you guys nervous that maybe in the adjuvant setting, given that Persevera didn't seem to have benefit, that maybe we won't see, if we were to do a trial comparing AI CDK to SERD CDK in the upfront adjuvant setting, that it wouldn't be any different? Or do you think this is a different setting?
I think there's definitely vulnerability there. Now, remember, you told us there was a favorable trend in Cambria 2, so that might have swayed our response.
In Persevera.
In the prior answer about Cambria 2. But in Persevera, I think what concerns me is when we combine oral SERD with CDK4/6 inhibitor in a population where we expect the rate of ESR1 mutation to be quite low, it may be that the efficacy from the combination with CDK4/6 overwhelms the benefit of SERD versus AI. And it's possible in the early stage setting where we expect the frequency of ESR1 mutations to also be very low that we could see a similar effect. So I think that's the reason why we have to have a lot of caution about use of oral SERD in combination with CDK4/6 inhibitor in early stage disease until we see real data.
That's quite fair. So maybe just a couple more of our questions. If giredestrant were available, regulatory and reimbursement issues aside, what would you generally recommend for patients who meet criteria for both CDK and giredestrant? It looks like a lot of people want to give endocrine therapy CDK and then switch to giredestrant if they could. So I think people would like that strategy if they were able to do it. And then we definitely said that if people are intolerant, this becomes really a nice strategy to switch people over. If adjuvant giredestrant were available, would you consider switching to that strategy for a patient who had hormone receptor positive localized breast cancer who's receiving standard adjuvant endocrine therapy, but difficulty across the board? Everyone's switching people over for tolerability, which is great. So I think this has been an amazing discussion. So thank you all. Clearly, we've solved all the controversies in breast cancer. So thank you, guys. And thank you again for joining us. We really appreciate it. Have a great evening, everyone.
Subsequent to the recording of this program, the FDA approved gedatolisib in combination with fulvestrant, with or without palbociclib, for adults with hormone receptor-positive, HER2-negative, locally advanced or metastatic breast cancer, without a PIK3CA mutation, following progression on or after treatment, with at least one line of endocrine therapy in the metastatic setting. This approval was based on results from Study 1 of the Victoria 1 trial. Please check out the official prescribing information for more information.